Yeah, it's really not too complicated. Kind of the post-op care really starts in the OR as we wrap things up. This is just a picture of David Saway in South Sudan. He's a ophthalmic clinical officer at Tenwick, and he's a fantastic MSICS surgeon. That's all he does all day long. So he, for every 2 I do, he does 3. And these were tough cataracts. It's kind of funny because I've never seen eyeballs like in South Sudan. Steve, have you been up to South Sudan? Man, I've heard the cataracts in Ethiopia are pretty nasty too. But man, you cannot get an easy cataract in that country. Everyone's got band keratopathy, pseudoexfoliation, tiny people. Half of them have had trauma on top of that. I mean, they're just some ugly, ugly eyeballs. And I went back to Burundi. I was like, oh man, thank God, I love the Burundian eye. So I don't know what's going on up there, but it's not pretty. But Saleh, man, he can crank them out. So anyways, kind of our routine care at Tenwick and in Burundi. So at the end of the case, we will give a subconj injection of dexamethasone and gentamicin, and we just mix it 50-50 out of the vial, 0.5 cc. Superiorly, I'd say one little tip if you do that, if you close your conj with cautery, and if you're superior, you don't necessarily have to do that. Some people like to do that. When you go to inject it, if you've got your wound, you've cauterized here, you don't want to inject it this way. You'll pull your wound open and have to recauterize. You want to inject towards your wound so that you don't pull your wound open. That's just a little thing you'll learn really quick once you do it wrong. But we put that in, and then we'll just put a little Maxitrol ointment or some Tobradex on the eye. I like ointment at the end of the case if we have it. Usually there's a shortage in Burundi, and we'll just do a drop instead. But if we have ointment, I'll use ointment. And then we just gently pressure patch the eye overnight. If we have a complicated case, at the end I will put in moxifloxacin from Oralab, the preservative-free moxifloxacin. Otherwise, on our routine cases, just if you look at the number needed to treat, it's a massive number needed to treat to prevent 1 case of endophthalmitis if your rates are reasonably low. So I don't do it on every case. Because if you look at people that get endophthalmitis, it's the people that have complications that usually get the endophthalmitis, at least at Aravind. And the people I've had have all been people with ruptured posterior capsule, usually with retina work. So for pediatric cases, some of you will maybe be doing some peds cases or kind of uveitic cases. Hopefully they've been followed before and you know they're quiet. But I will give my kids, especially little ones, some sub-tenons triamcinolone, 20 milligrams sub-tenons as well before they leave the OR. So post-op day 1, if you're at a camp like this camp in South Sudan, we'll just do a super fast pen light exam. I mean, there's 90 people to see, so you just walk down the line. And then in this situation, the post-op care is just standardized. Everyone's going to get the same thing. And then if I saw someone that needed something else, like we weren't checking pressures either, but if someone had a cloudy cornea, I'd take a piece of tape and write Timolol on it and slap it on their forehead. And the team behind would come in to tell them how to take care of themselves different than the rest. So there's kind of really efficient ways to take care of a lot of people really fast. But someone on the team will go ahead of you and they'll take the compress off and clean up their eye with a sterile saline and a gauze. And then if we're at home base, I'll take a look at the slit lamp. Otherwise, we'll just do a pen light exam. At home base, if the cornea has any microcystic edema, we'll check a quick pressure. If it's a trainee doing it, I do make them check the pressure on all their patients. For my routine cases, I don't. Some people would probably say you should. But if the cornea is clear, and I don't check it on every single patient. We'll start, usually we have like Dexclora or some other steroid antibiotic combination. It doesn't really matter. Anything you got, you can do we do that, start it 6 times a day. And then that'll be followed by, we'll give them a second bottle of just steroid, and we'll just do it 4 times a day. I used to do a taper, but in our setting, it's complicated to explain. It probably doesn't happen well anyways, even if we take the time to explain it. So we've moved to just trying to keep it as simple as possible. We just write 6 on one bottle a day and 4 on the next, and say, do this one first. When it runs out, start this. And we don't have a whole lot of rebound inflammation when we've done that. It seems to be working out okay. We have an occasional case. When we have shields, we'll use them, but we often do not. Like at this camp, we didn't have any shields. And I've never had someone come back with a major complication from bumping their eye. Does anyone else have experience with that? Has anyone seen an M6 wound post-op get burped open and have a need to go back to the OR? Steve, have you ever? I've never. The only one I had was my second M6 in the US. I was working with an attending at an inner city hospital, and it was a tough cataract, and we got in trouble. I was a senior resident. The lens was hanging by a thread, and he's like, oh, let's convert. He had heard I was getting into M6. He's like, well, we can try your M6. I was like, sure, let's go for it. And so we converted to M6 in kind of a soft eye with vitreous, and it was not an ideal situation, but we got it out nicely. And there must have been a little wick of vitreous in the lip of that M6 wound, because later he went home and I think he was having a bowel movement and strained, and he burped a knuckle of iris out the wound, and he was fine. But we had to take him back to the OR, a day later to suture his wound. But that's the only time I've had a problem. And if he was wearing a shield or not, it wouldn't have mattered. So I personally, I don't really even care that much if they wear a shield. If we have them, we'll give them out. But it's not the end of the world, I don't think, if they don't get a shield. And then we'll give the patients endophthalmitis warning signs. And then I've been moving more and more to having them come back in a month. These patients, as you'll see in this next picture, not that one, sorry, coming later, they can come from a long ways away. And to come back for a 1-week check on a routine cataracts, how often, unless they have endophthalmitis, is that really going to change what you're going to do? Not very often. So they just have the warning signs, and if they need to come back sooner, they can come. Otherwise, I've been pushing more. We're randomizing our patients, actually. We have a map, and I just drew a 30-kilometer circle around Kabuye. And if you're inside the circle, I have you come back at a week. If you're outside the circle, I tell you a month, and we're going to look at our data to see the outcomes, if there's any difference. And I bet there's not. But it's probably because I have to come up with research ideas for all the medical students, because we have 40 medical students at a time, all the time, and each of them has to do a senior thesis. And so I have to come up with all sorts of research ideas. And I'm not the smartest researcher, so I come up with simple ideas, which sometimes come up with the best data, actually. So we're going to kind of look at our numbers and see if really it's even necessary for a routine cataract to be seen. I think even in the States, they're moving more to 1-month follow-ups, aren't they? Yeah? So I think the same's true there if it's a clean routine case. Anyway, so post-op day 1, in special cases, pediatrics, I'll put them on every hour because, man, the kids can really get a lot of inflammation. And we're using PMMA lenses, not your nice, special lenses in the US you would use. So they can get a little more sticky on the lens, so you really want to really hit the inflammation hard with steroids. So they've already got the sub-tenons. I'll hit them with topical. There's some data that says you don't need to add oral steroids, but I sure think it helps. There's a study out of Tanzania that showed it didn't make a difference, but I feel like it does. I don't have good evidence for that, but I'll put the kids on 1 milligram per kilogram of oral steroid too, just to keep their eyes super quiet for 5 days. And it's easy. In Africa, you can only get 5 milligram steroid tablets. So if you do 5 days, you just give them the number of tablets as their kilograms, and it's easy math. So if they're 20 kilogram kid, they need 4 tabs a day times 5 days. That's 20 tabs. So it makes it easy for me to just write 20 tabs. And then I used to do more frequent like cycloplegia, but then sometimes the iris gets stuck out there in those uveitis or those kids. So I try to keep the iris moving, is more my idea. So I'll just have them do it like once a day to try to keep the iris moving so that it doesn't get stuck down somewhere. Just in the background, this is a lady in South Sudan that came. Those are her 3 kids, all blind with cataracts. No access to eye care, there's no hope for her kids to ever see again until we came to, because that was northern South Sudan, and the largest refugee camp. There's 400,000 refugees. Juba's in the south, and it's a death march to get there. I mean, they could have never gotten there. But her husband was blind and died already, and so we did her 3 kids on that trip. But anyways, yeah. So these people are coming. It's tough to get to care. So I think if you can spread out those post-op cares visits, it can be really helpful for the patients. So at week 1, if they do come back, we'll take a quick look at them, and we'll consider tapering their steroids or bumping up their steroids. But again, kind of looking at not doing that. At a month, we'll take another look at the slit lamp. That's when I'll make sure there isn't kind of any low-grade glaucoma going on, take a look at their optic nerve. I don't dilate every patient. If I can get, I've gotten really good at looking through tiny little pupils with a 90. But I'll just take a quick look at their optic nerve, make sure we're not missing glaucoma, and I'll do a quick finger pressure. If it's borderline, we'll do more. If you use your fingers a lot, you can actually get pretty good. You have to double check yourself, but I use my fingers a lot to be fast. But I always look at the nerve too. So it'd be interesting just to do a study on how many people we might miss if you're not doing a IOP on every single patient. But then we'll check them for glasses. And again, we'll adjust their steroids, and that's about it. It's not really too complicated. For most people, they're just getting 2 bottles, a bottle 6 times a day, the second one 4 times a day, and that usually does the trick. Any questions? Yeah, they're out with everybody else, but what we'll do is usually, there'll be a senior kind of clinician, technician kind of person that's going to give the post-op instructions. So they'll usually have a megaphone, because like at this camp, there's 90 people a day getting post-op instructions. So they would kind of, one side identify with tape who's going to get different care. They would set those people aside and be like, well, they'd say, listen to what's going to be said. You're going to do everything they're going to do, but then after, we're going to tell you a couple extra things to do. And then with a megaphone, they'll go over, how everyone's going to take care of their eye, and then the complicated ones that need timolol or a couple tablets of Diamox for a day or 2 will get set aside, and they'll get a little extra instruction after that. But that's kind of how we do it in mass to be efficient, because that guy then has to go see another 500 patients. At that camp, that was insane. Like the UNHCR was busing in blind people they had screened with the Red Cross, Doctors Without Borders, the whole camp. And so they're like busing in busloads of blind people. It was insane. It was just like a sea of blind people. I've never seen anything like it. So when we hit the ground, they already had 500 people ready for cataract surgery. So it was busy. But
not a good training situation.
No, seriously, yeah. I mean, we were operating day and night because we knew we wouldn't, there was more need than we could do, but we worked as hard as we could and efficiently as we could. But, and we did more than we expected to do, but yeah, it's a tough place.
John, do you manufacture your own glasses then
In Burundi, we do have our own optical shop and grind the lenses there. But on these trips, we'll just take, some standard glasses. We won't be able to take specific orders because we don't refract. It's more kind of presbyopic correction on these kind of trips.
Where do you get your supply drops for Burundi?
Yeah, we have some local suppliers, but for post-op drops, because I know I'm going to need a lot of them, and I really want to know the quality is good, because the local suppliers are getting these crazy brands from China and India. I really don't have a whole lot of, I don't know what's good. Some of them are fine. I think some of them probably aren't, but I don't know which ones are. So for critical medicines, I get my stuff from Oral Lab. It's kind of one-stop shopping. I can get all my IOLs, viscoelastic, all my surgical supplies from Oral Lab, plus, they have an inventory of 50 eye meds. So about twice a year, I'll put in a huge order with Oral Lab. And it's probably 50 cents for a 10 ml bottle of Dexclora. So you can't beat the price. And I trust the quality, because they actually test each batch. They send it with proof that they checked the med to make sure the volume was right in that batch and that the chemicals were active and what they thought they were. So they have a high standard of auto check at Oral Lab. So I trust their stuff. I will say, for whatever reason, their Timolol leaks in transit and their cyclosporin. I don't know why. Those two things, we get a lot of, you can tell it leaked at some point, and I don't know why. It's the same bottle as all the other stuff. But we have problems with the Timolol and cyclosporin for some reason. But everything else I've never had a problem with.
And where's Oral Lab located?
No, that's India. It's Aravind Eye Hospital. So basically in the 1980s, as people moved to IOLs, or early 90s, they're like, man, we want to be doing this, but it's too expensive for our patients. So they just built their own factory. And so they produce pretty much anything you could want for eye care. Because they're doing 300,000 cases a year themselves. So they wanted to do it as cheaply as possible. But it's really good stuff.
And you can ship it safely through countries?
Mm-hmm. Yeah, it's a hassle. I have to get it all through customs and stuff. But
The United States?
certain things have a CE mark. I don't know what things are cleared for the FDA yet or not. I think they're probably working on it because they have high quality sutures. I actually prefer Oral Lab suture over Ethicon 10.0. I really like their suture.
We can't ship it in the States.
Yeah, I mean, I know certain things are okay for Europe because they have a lot of products, frontalis slings and the tubes and shunts, tube shunts. But for the tube shunts, Ahmed will give them to you for free from New World Medical. You don't get as low as pressure as a valveless tube on that, but when I'm doing a tube, it's usually just to get people through a really, really high pressure, not to get their pressure rock bottom low.
For your uveitis patients, even here in the U.S., a lot of times we're doing the prednisone before the surgery.
Yeah, I do that too, yeah.
It would be interesting to see, are you just starting it the day of surgery?
If they come, usually the uveitis patients, we're not going to operate on them the first time they come because they're not quiet, usually. So I will give them medicine to start before. I usually will start them 3 days before the surgery if I have the chance. Obviously, because you don't want to make a mess of their eye, especially in Africa. It's even more important to make sure they're quiet because they're not going to have as good as PostOp care probably. So,
Because that's what we're finding is doing better, getting the PO prednisone in there a few days
yeah,
ahead of time.
yeah, I'd like to do that.
For our patients that go for dental surgery, we'll even do it for any type of trauma to the body. We'll start it early and it seems to be much better.
Yeah. Yeah, and I have methotrexate too. Some of our people have had, that need long-term systemic stuff. I can get methotrexate from India. So it's kind of what I use as my steroid-sparing agent.
In your big camp like in Sudan, what was your ASCRS cure time? How did you just get that all done all over the patients?
Yeah, so I mean, it was a beautiful thing. I was the only Westerner, and I was just there because they asked me to come as a second surgeon because they knew they had so many patients. The entire thing was 100% organized by African professionals. SP has Kenyans up there running their base camp. I mean, it's a war zone. Kenyans are up there, super. They're just so organized and on top of pre-screening and registering and having everything so well organized with all these different NGOs. But Wilson Karich, he's got, I don't know if he even finished high school, but he is a wizard. He's super smart. And he's just learned how to do A scans and B scans and refractions and make glasses. And so yeah, he just crank them all out. So we have an A scan and a handheld keratometer. Tenwick does. I have one, but it doesn't work very well. I've kind of abandoned it, sadly. So we have to, I take our whole Bosch and Loam when we go on mobiles, which weighs a ton. I mean, things are like a tank. But that's what I have to do. Those things are expensive. Those handheld keratometers for like PEDS cases are like $14,000. So I had a cheap one from China that someone gave me, but I had a really tough time. You have one you can get for $3,000? Does it work consistently? Yeah? Let's talk. I need to get one for my kids. Yeah. All right?
Yeah.